insurance in response to the excise tax will get a person, such as one with a chronic condition like diabetes, to reduce their use of healthcare services. The appropriate comparison is not the out-of-pocket expense difference between the lower and higher cost-sharing amounts. Instead, the appropriate comparison is out-of-pocket spending differences between lower and higher healthcare use amounts at the higher cost-sharing level. If coinsurance was 10%, reducing the use of healthcare services from the average of $10,000 to $8,000, a 20% reduction in healthcare use would save an individual $200, regardless of the level of deductible. Similarly, if coinsurance was 20%, reducing the use of healthcare services from $10,000 to $8,000 would save an individual $400. An important question to ask is whether the $200 or $400, and these are just examples, is large enough to reduce use of services by 20% for a person with a chronic condition such as diabetes. If a person with diabetes does not change his or her use of healthcare costs will not be affected. Researchers have noted the negative effects of increased cost sharing on patients' compliance with prescribed drugs. They found that while increased cost sharing is effective in reducing drug costs, it could also result in higher spending for other medical services. In other words, higher cost sharing can and does reduce healthcare spending, but in some cases it reduces beneficial healthcare spending on prescribed medications and preventive services. A number of employers and health plans have recognized these suboptimal behavioral effects and have begun to explore ways to counteract them, either by excluding the cost of preventive services from plan deductibles, by adjusting co-payment amounts by the value of the services as opposed to just the cost, or by rewarding good health behaviors. Mr. Chairman and members of the caucus, I commend you for exploring these topics, and thank you for the opportunity to appear before you today.
Mr. Chairman, thank you for giving me the opportunity to introduce our next witness, my good friend Jim Martin, who is president and actually the founder of the 60 Plus organization back in 1992. Jim currently represents some 5.5 million seniors. These are his words, not mine, but his organization is viewed, in his opinion, as a conservative alternative advocacy for our seniors to the much larger American Association of Retired Persons. And Jim will, I'm sure in his testimony, explain the differences in the two organizations, but it will be instructive. I've read his testimony. I look forward to it and look forward to the opportunity to ask additional questions of Jim as to the view of the 60 Plus Association in regard to their lack of support of this comprehensive health care reform bill, whether it be the Senate version or the House version. So it's a great deal of pleasure that I introduce the next witness, my good friend, President and Founder of the 60 Plus Association, Mr. Jim Martin.
Thank you, Dr.